So let's come to the first case, which is the case of inguinal hernia. And you will be asked that this is your case and you are required to examine him. So the patient will briefly tell you that I have got a swelling. So brief history. So let's come to the crux. There will be a brief history, and in that brief history, what are the things that you are going to ask in that brief history? You are going to ask basically where is the swelling? So where, that means you are talking about the groin region, and then you would ask how long duration of this swelling, because that's a very important thing. And if you have not been asked to you have already done the case, you have taken a little bit of a history before you did the examination, the examiner may say, okay, just tell me the important questions which you will ask. So where is the swelling, how long has the swelling been, and have there been any events related to the swelling? Now what are the events that you would think about which are relevant to this particular swelling? You would talk about a history of irreducibility or history of distension of the abdomen associated with vomiting, which means that you are talking about a case of an obstruction that has happened and the patient has had an episode of or if there has been any acute intervention needed, which needed a surgical procedure in the emergency, that needs to come out. The other thing that the examiners may look at or want you to tell perhaps would be what could be the cause behind this swelling in the groin. So you would be expected to know that any chest complication like COPD, patients with chronic constipation who are exerting pressure, or patients who have got lower urinary tract symptoms, LUTS, who are again straining for micturition. These are the three basic things, and very rarely, but these are not common things, is patients who are doing physical work which requires heavy lifting of weight. This normally does not come as a very significant issue. You cannot pinpoint because everybody is working and it's very difficult to say whether they have actually lifted a very heavy weight and it resulted into a groin hernia. But usually these are chronic issues which we talked about, that is COPD, chronic constipation and LUTS, and you should be able to highlight these events. So in the history, that is something that is important. If you were to look for hernia and start the examination, you are expected to have seen the patient both in the standing position and in the supine position. So very important, this is, you need to say that I have done the examination in the standing and in the supine position, because inguinoscrotal swellings are best seen in the standing position. So your description, which is going to start with inspection, palpation, percussion, auscultation, is going to be, the inspection component is going to cover that I saw the patient in both standing and supine position. If the patient is in front of the examiner and the patient is lying down, it is good enough to say that I would like to make him stand up, but I am able to see this swelling when the patient coughs, or the patient may already have a large swelling which may already be visible even without the patient needing to stand up. In that case, you do not really need to ask the patient to stand. So what are the findings that you would say on inspection? On inspection, you should be able to say, so this is the inspection of the patient, that's the groin, whether there is a swelling which is inguinal or coming into the beginning of the scrotum, or clearly inguinoscrotal. You should be able to show these three things. So this is what is talked about as an inguinal swelling. This is becoming inguinoscrotal beginning part, and this is the inguinoscrotal swelling completely, which is known as a complete hernia. So on inspection, you should be able to say now whether it is inguinoscrotal swelling only, or the other differential which is likely to be is if it is only a scrotal swelling, and you can clearly see the demarcation between the groin. You can see clearly that this is confined only up to the in the scrotum. You can kind of see that it is a scrotal swelling. So this is the important differential which will come in, which is differential for any swelling that is arising from the scrotum. That could be, do not jump to just saying hydrocele. This could be a testicular swelling. It could be a testicular tumor. It could be a swelling related to the investing layers, which is a collection of fluid, which is hydrocele, which is a very common condition. Or it could be a lesion coming from the scrotal wall itself. So whatever it is a scrotal swelling. So on inspection, you should be able to differentiate to tell the examiner that this above component is a hernia component and the lower component is a hydrocele component. So this is the part which is going to be seen on the swelling part. Then you will say that the swelling has, you got to say that there is a visible cough impulse. So if we were to add other components, so to the inspection part, there will be a visible cough impulse. Now the only condition when the visible cough impulse will not be present is when it is an obstructed hernia. In all other cases, you will be able to see a visible cough impulse. The visible cough impulse actually means that the hernial sac is in continuity with the abdominal cavity, and the thrust which is coming because of the increased abdominal pressure is actually showing onto the swelling. So visible cough impulse is a very important sign of a hernia. So other than that, you will talk about the stretching of the skin if there is any, that is especially when it is a inguinoscrotal swelling, and deviation of the penis to the opposite side if there is any. And sometimes in a large hernia, you may be able to see visible peristalsis on the skin. You should be able to say that. So if there is any accompanying discoloration of the skin, that also needs to be mentioned, that there is an overlying discoloration of the skin. Overlying scars of previous surgery must be seen. Scars of on the opposite side, because look here, this is not just a groin examination, this is a complete abdominal examination which you are going to say. So there could be a finding where you have an umbilicus and you have got a umbilical hernia as well. The patient has been given to you for a inguinal hernia, but that does not mean that you will ignore the umbilicus here if you've got any finding. So look for scars elsewhere of previous surgery. Look for any signs of sinuses or other insults that have taken place around that. So do not miss the skin finding. So that is almost the important components. Now the next important component is the site of the hernia. So on examination, you should be able to, let's move on to the next bit of it so that we are able to understand. So if you see the groin, then we are talking about the differential diagnosis. So differential diagnosis here is a direct inguinal hernia, an indirect inguinal hernia, and a. Now, can you differentiate this on inspection alone? Look at that. It's very important. So we have got a landmark here, which is the pubic tubercle, which is not seen but palpated. and 1.25 centimeters above and lateral to it is the opening of the superficial inguinal ring, and the marking for the deep inguinal ring is 1.25 centimeters above the midpoint of the inguinal ligament, which is somewhere here. So the cord structures which are coming from the groin downwards are coming like that and going towards the scrotum. Now this is what you need to understand. An indirect hernia is going to come alongside here. So, and a femoral hernia, let's talk about it. This is important anatomy for you. The femoral vein is going like this. Femoral artery is lateral to it, and the femoral canal is actually medial, through which the femoral hernia comes out. So, if we were to talk about the femoral hernia is going to come out from the femoral canal and balloon upwards like that. So the difference, the classical difference that happens is that the indirect inguinal hernia, so indirect inguinal hernia is above and medial to the pubic tubercle, and the femoral hernia is below and lateral to the pubic tubercle. So it's very important, and this can be sometimes be picked up in the inspection itself in a small hernia. The cough impulse, the site of the bulge can be seen on inspection, and you can then reconfirm it on palpation. So once this is done, and the third component is the direct inguinal hernia, and the direct inguinal hernia will come as a bulge in this area because it is medial to the inferior epigastric artery, which comes here. So the hernia indirect sac which we had drawn comes alongside here, and the direct hernia comes from the medial side, that is from the Hasselbalch's triangle. So this is the margin of the rectus, this is the triangle, and the bulge will be seen directly. So you should be able to see the bulge of the direct hernia. This is the bulge of the direct hernia, this is the indirect hernia, and this is the femoral hernia. So you should be able to see the direct hernia bulge directly in the region of the Hasselbalch's triangle, which will be above the pubic tubercle area and on the medial half, as you can see, medial half of the above the inguinal ligament. The indirect sac will come out above and medial to the pubic tubercle area, and the femoral hernia will come below and lateral to the pubic tubercle. So this is the important point which needs to be seen when you have got a incomplete hernia which is giving a cough impulse. It's very important to make a difference here. Then comes to palpation, which is your second step, and on palpation you will say that I'll confirm all the findings of the inspection, and it is important here to palpate. See, the two important things that we start with is temperature and tenderness. The basics of inspection are 5 S's for any swelling. Let me come back here to inspection. The 5 S's of a swelling: site, size, shape, surface, and surrounding skin. These are the 5 S's on inspection. And on palpation, there are 2 T's: temperature and tenderness. So you will start with saying that I have on palpation, the temperature is normal, there is no tenderness, and I am confirm the findings that number one, this is an inguinal swelling or an inguinoscrotal swelling or a completely scrotal swelling. If you say it is a scrotal swelling, that means you are going to get above the swelling. If you cannot get above the swelling, then it is definitely an inguinoscrotal swelling. So in a hernia, when we are talking in terms of an inguinal or an inguinoscrotal swelling. You will say that I can see the swelling is coming. I'm able to palpate the pubic tubercle. My initial impression that this is an indirect hernia is confirmed because I can palpate the pubic tubercle. How do you palpate the pubic tubercle? You palpate the pubic tubercle by starting from the pubic symphysis. So this is the symphysis pubis. You start at the midline. So it's easiest to go bang into the midline and go laterally. The first bulge that you find is the pubic symphysis. Similarly for the other side. So pubic tubercle, pubic symphysis. So I've been able to palpate the pubic tubercle and I can find that this swelling is going above and medial, therefore it's an indirect hernia. It is coming directly from the Hasselbalch's triangle, therefore it looks like a direct hernia, and it is going below and lateral, it could be a femoral hernia. But the differentiation between the direct and indirect is done by a test. So that also is a part of the palpation itself. Majority of the inguinal hernia is going to be done during palpation itself. There is nothing much in auscultation except you hear for the vowel sounds, and there is nothing much in percussion also, because if there is any vowel there, you will be able to get some tympanic note. So percussion and auscultation are not very important components of the inguinal hernia examination. It's mainly inspection and palpation. Now, what is the way? And that is what we find people struggling in examination as to difference between the direct and indirect hernia on the palpation. So let's come to that. So there are number of tests that are described in books, but I would like you to say that examiners do not like anything other than the deep ring occlusion test. And for your understanding, I'm writing it so that that is the only test. This is the only test that we want to hear, is the deep ring occlusion test. Now, to differentiate between a direct hernia versus an indirect inguinal hernia. So, what is the prerequisite of doing a deep ring occlusion test? You need to reduce the hernia completely. If it is irreducible hernia, can you do a deep ring occlusion test? Of course not. You cannot do. In a complete irreducible hernia or a complete hernia, which is any hernia which is irreducible, you cannot do this test, and hence in that case you will not be able to say direct or indirect, but you may say it is likely to be what, because of the direction of flow of the hernia itself. So be very mindful of that. Now, deep ring occlusion, as I already said, deep ring is the U-shaped defect in the fascia transversalis, which is 1.25 centimeters above the midpoint of the inguinal ligament, which is laterally placed. So it is the inner part of the inguinal canal, and the cord structures are coming through the deep ring and then out through the superficial inguinal ring, that is the deep inguinal ring, and the hernial contents are coming alongside it like this. This is the sac. So the content needs to be reduced. The sac is staying there. Then after reduction, I have done the deep ring occlusion test. That means I have occluded it with my thumb, and your thumb pressure goes there at this area. You put the thumb and you occlude the deep ring, and you ask the patient to cough or you ask the patient to stand up. The hernia does not come out. You remove your thumb and the hernia comes out, and this proves that this is an indirect hernia. If the cough impulse continues to come with your finger in place, then this is a direct hernia. So that's very simple. Please do not try to do finger invagination test or Siemens test or a 3-point test, because this is very painful, uncomfortable, not reliable, and examiners do not like to hear these tests. So the only test that we are looking for is a deep ring occlusion test. On palpation, you will also be able to say whether it is a indirect or direct hernia versus a femoral hernia. As I already said, this will be coming from below and lateral to the pubic tubercle and then coming up. The sac comes up and then they confuse. So that is why you have to use pubic tubercle as the site to differentiate between the two structures. Now, what about the direct hernia? Direct hernia is a direct bulge. Because it's a direct bulge, it seldom goes alongside the cord structures. So if you have a inguinoscrotal swelling, it is not likely to be direct hernia, it is more likely to be an indirect hernia. So if you say that, sir, this is an irreducible swelling, it is going into the groin, I am not able to reduce it, but my likely diagnosis is a possible indirect hernia, though I could not do the deep ring occlusion test. So after having done that, finishing your examination, you will be asked to give your final diagnosis. So this is very important. Sometimes examiners would like to ask that straight away. So what is the diagnosis, doctor? They may like to say that do it straight away. So commit yourself to a diagnosis and then they will work backwards. They will start with the short case. They'll say, okay, put your diagnosis. Then you cannot put a signature there with your diagnosis, and then you cannot be allowed to change. So what is a good diagnosis? So let's say this is a right-sided, complete, reducible, inguinal hernia, indirect, inguinal hernia, which is a enterocele. Now, how do you come to know? Right side, because it's on the right side, very easy. Complete, because it is able to come bottom, it should be able to come to the bottom of the scrotal sac. If it is not complete and you can see the testes or palpate the testes separately, it is not a complete hernia. So reducible, because you are able to reduce it, so you have to say that. And then indirect, because you are able to do the deep ring occlusion test and it shows that the hernia does not come out when your finger is occluding the deep ring. So it's an indirect hernia. And why do you say the content is an enterocele? Because the hernia reduces easily and it is not doughy in consistency, it is more elastic. So when the feel is elastic versus the feel is a bit more doughy, then it is likely to be a omentum. If it does not go back easily, it is likely to be an omentum. Not that bowel will not go back, but I'm just saying it is between the two. When the omentum comes, it is easy to for the omentum to develop adhesions between the sac, peritoneal sac and the omentum. Therefore, it becomes a bit irreducible. So when it is elastic, it comes in smoothly and it goes back easily as well. So these are the ways in which you are going to describe all the components. So complete or incomplete, reducible or irreducible, direct or indirect, enterocele or an omentocele. If you are able to say that, then this is a complete diagnosis. Then the examiner is going to say, what is your likely management? So you will say, sir, depending on the patient's age and fitness, I would like to choose, and the training that I do. Nowadays, I have been exposed to minimally invasive hernia surgery, and I would like to offer this patient transabdominal periperitoneal repair or a totally extraperitoneal repair. However, I am not trained in it. I am very well trained in open surgery. I would like to offer this patient an open, classical open Lichtenstein hernioplasty, which is a tension-free repair of hernia, and like that, the Viva would end. So, I hope you are clear with this particular short case.